we deal with patients. Yes. And now, thanks to all the academies all around the world, and thanks to Professor Oliver Gültig, he was awarded lately to become Sir Oliver Gültig from Germany for improving the knowledge and sending it everywhere. So it's a good opportunity today, and I'm very thankful to Mr. Jobin and the Academy. And I wish you enjoy the meeting and open your mind towards the lymph patients and the lymph rehabilitation rehabilitation procedure. And of course, I welcome you all, and I'm very happy that there is a participants that are interested in the lymphedema management, and I wish to see you all certified lymphedema therapists from Gültig Lymphology in Frankfurt, Germany. So if you allow me, I would like to start now my lecture. Is everyone, does everyone agree to starting now? We start the lecture now, okay? Yes, thank you, Dr. Muhammad. We are all motivated. I'll share a document now. That's our lecture for today. We will be talking about the fundamentals in lymphedema management. I'm Michel Fathi. I'm consultant of physiotherapy and an international lecturer at Gültig Lymphology and head of lectures at Gültig Lymphology, Frankfurt, Germany. And I'm the head of departments at Cleopatra Hospitals Group in Egypt, and the head of the German Lympho Center, and the head of the Egyptian Lymphedema Therapy Association in Egypt. I wish to see a lymphedema association in Kuwait, inshallah, so soon. So the title of our lectures would be the fundamentals of lymphedema management, and I'd like to put two lines below fundamentals because it's only the fundamentals. We will know a lot today, but we must know that as much as we know, we need to know more because lymphedema is a very big branch. You will deal with patients with oncological problems, with chronic venous insufficiency. So you have to read in every subspecialty, even with the bariatric surgeries and the liposuction. You have to read about every every subspecialty and how you deal with those patients to become not just like a practitioner. We have to be doctors. We know how to do a diagnosis. We know which is indicated for the treatment and who is not indicated for this type of treatment. At the very beginning of our lecture, I'd like to tell you, never underestimate the word of mouth. When you know how to help others and how to spread your knowledge, you have to talk to everyone. Talk in your hospital, talk with your groups, talk with your friends about lymphedema and how it could help the others, and how much is the suffering of the lymphedema patient and how much you could help that type of patients. We established the Egyptian Lymphedema Therapy Association, and that was 2024, and we have made a lot of success since that timing. And I wish, of course, to see the Kuwait Lymphedema Therapy Association to make collaboration with Egypt, inshallah, very soon. To know how much of knowledge we can get, we have to know the levels of education of Gültig Lymphology. The Gültig Lymphology starts education with a primary level that we call an introductory certification. The introductory certification, we stay together for about 3 days. We talk about the lymphostatic diseases, the pathology, the anatomy, the pathophysiology, and then we start doing some manual lymph drainage and how we can do the compression therapy and how we can plan for treatment of every case. It's a very primitive certification that opens your mind for your need to know more and to see more and to know much about the lymphedema treatment. And when you're interested in lymphedema, so you can get to the second level, which is to be a CLT or a certified lymph therapist. The certified lymph therapist is a well-known worldwide name. If you're going to the hospital and you're asking to be treated from lymphedema, you will always ask, is there a CLT? Is there a certified lymph therapist? And by this certificate, you will have to go through an online study for about 30 days where you go through the anatomy and then you take a small test, physiology test, pathophysiology test, lymphostatic diseases test, and then when you pass all the tests, we've got to get together for the hands-on and discussing your questions for about 10 days, 9 to 10 days. And after that, we take a small test and then we become certified from Gültig Lymphology, Frankfurt, Germany. And the third level, the third level is the advanced certificate. This advanced certificate is given to the CLTs only. After practicing for about 1 year, I think then you will have a lot of questions. Like if you do compression for the lower leg, you can see sometimes it happens a dermal backflow where the thigh circumference is increased. What can we do with the lymphedema genitalia for the male and the female? Can we do manual lymph drainage when there is a lymphedema genitalia with a virus like the human papilloma virus or not? This is a very advanced questions where we talk in depth how to do the bandaging for the scrotum or the genitalia. And after the decongestive phase, how can we maintain the results that we have got? So that's the 3 levels of Gültig lymphology. You can go through the introductory certification at once, and you can go, of course, to the CLT at once without going through the introductory certification. But for the advanced, you have to be a CLT certified lymph therapist from Gültig lymphology at first. That's the medical doctors and the lecturers at Gültig Lymphology, and I'm very proud to be one of them and the head of the lecturers, along with Oliver Gültig himself. That's a brief about Gültig Lymphology. We have certified more than 1,000 medical doctors and over 40,000 physiotherapists all around the world. So let's start. I want you to look at those 2 pictures, and I always start any lecture by these 2 pictures to show you what a lymphedema therapist can do. If you look at the left picture, you will see a nice girl from Sudan. She was suffering from filariasis, and as you can see, the edema here is impressive. It's enormous. And that enormous edema caused her to walk as if she is pulling her legs while she's going. Can you see the forefoot and how is it looking, and the lower leg? And only by the complete decongestive therapy from manual lymph drainage to compression therapy, we could reach that look, as you can see on the left side. Now she's wearing a compression garment. That compression garment is made to measure. It's flat knitted. It's made in Germany. It's made specially for this girl. After finishing her treatment, she could walk freely as good as we can walk. And on the right side, you can see here this guy was suffering from a chronic venous insufficiency and ulcerations, as you can see on this picture. And these ulcerations, as we will talk today in the secondary lymphatic edemas or the phlebolymphedema, is due to the inflammatory process and the inflammatory mediators and the interleukins that is ultrafiltrated through the skin that caused inflammation, and then the skin started to burn out like this. And as you can see, we can see his soft tissue and his muscles under this ulcer. And only by compression therapy and skin debridement we could reach that result. He was completely safe and sound, and he could put on his compression garment and live his life again. Okay, I was making a lot of markings here, and as I start, I'll have to take off all these markings. That pictures shows us, because we will start to talk about the lymph or the lymph fluids, we have to know at first how the lymph fluid comes to the interstitial space and what is lymph and what does it do. So at first look at the picture in the middle here, along with me please. That picture in the middle describes the arterial and the venous circulation. As you can see here, this is the artery, this is the arterial circulation. Nothing's happening. Draw. Yes. This is the arterial circulation here, as I'm pointing, and this is the venous circulation. The blood circulation starts with the arterial circulation. So the blood comes from the arteries and it would be coming from the heart with a very high pressure. So we see the pressure at the arterial end, as you know, it would be about 100 millimeter mercuries. 100 millimeter mercuries. And when that arterial pulsation comes to the capillary, it starts filtrating fluids from this space. When the blood reaches the venous system, it reaches with only 20 millimeter mercuries, a very low pressure. And by this high pressure, when it goes through the artery, it begins ultrafiltrating a fluid to that space. And this space, you can see it here on the right side, it's very accurate. Arterioles, goes to the arterioles, and from the arterioles back to the venules. And between the artery and the vein starts pulling out that fluid. That fluid, we will call it an interstitial fluid. It's not a lymphatic fluid. It's only an interstitial fluid. It stays between the cells. We only call it a lymphatic fluid when it enters the lymph system, not when it's in the interstitial space. So now when the interstitial fluids come out at that point, again to our first picture, okay. When it comes to that point, it starts from this point to be loaded on a protein that we call albumin. Let's mark it as there is cells of albumin here or particles of albumin. Albumin is a protein. That albumin protein is manufactured in the liver. So the liver will do the metabolism of albumin. When we have that protein in the interstitial space, the albumin, it starts sucking that interstitial fluid inside the albumin particles, what we call an osmotic oncotic pressure. The albumin starts pulling or sucking that fluid with the osmotic oncotic pressure, so we have albumin loaded with the lymphatic loads. Okay, now the albumin takes the interstitial fluid inside it, and then the albumin starts with the interstitial fluid to enter the lymph system. The first thing to enter the interstitial fluid is the primary lymph capillary. It's a very minute capillary. We are talking about a 10 micrometer in diameter. It's like 1/10 of 1 millimeter. It's very minute and it's directly beneath the skin. And from this position, the fluid starts going into the primary lymph capillary. Now, the primary lymph capillary the fluid have entered in the primary lymph capillary. So from this point, we can call it a lymphatic fluid. When it was between the artery and the vein, the cells, we called it interstitial fluid. And when it started going inside the primary lymph capillary, we called it a lymphatic fluid because it entered the lymph system. What differs the primary lymph capillary from any capillary? That the primary lymph capillary is valveless. When you look up left, the primary lymph capillary is completely valveless. Valveless. It means that there is no valves, no bicuspid valve, and there is no motoricity inside the capillary itself. It's just like a chalumeau. It's completely stiff and there is no bicuspid valves inside the vessel. And as we go back to the primary lymph capillary in the middle picture, the fluid starts to propagate from primary lymph capillary going through a larger capillary that we call a precollector. It's larger than the primary lymph capillary. And from the precollector, here we start calling the lymph system the active component of the lymph system, because the Precollector have got a bicuspid valve and smooth muscles that we call lymphangions. Let's look up left again. That's the precollector. Let's call it the precollector. And the precollector have got a bicuspid valve, and a minute micro smooth muscles that we call lymphangions. The lymphangions will start pushing that fluid upwards towards the bicuspid valve, so it passes and there is no reflux back. It prevents the back reflux. The lymphangions or that micro muscles, I'll show you a good picture of the micro muscles in the next slides, but those lymphangions will start pumping the lymphatic fluid from one level to the other one by the from one level to the other one, and this we call a lymphangiomotoricity. We call it a lymphangiomotoricity. It's the ability of the lymph system to transport the lymphatic fluid from one level to the other level. So the lymphangion, it pumps the fluid, it starts pushing the fluid, it holds the fluid this way and it pushes the fluid so it can go from one level to the other level through a bicuspid valve. The bicuspid valves open and then the fluid goes up, and then the bicuspid valve starts to close again, so it prevents the dermal backflow or the fluid from flowing back. And that's what we call the lymphangiomotoricity. The lymphangiomotoricity of the of the precollector is 5 to 7 pumps per minute. 5 to 7 pumps per minute. It's a very slow circulation, as you can see. And because the lymphangions are very minute and the lymph capillaries are very minute, the transport capacity is very slow per day. And if you imagine the venous circulation per day would be about 7,500 liters per day. When we compare it to the lymph system, it transports about 2 to 3 liters per day. It's a very slow, weak circulation of lymph fluids. That very slow lymph circulation is totally responsible on the immunity. It's the main immune system in our body, because the biggest organ in our body is our skin. And when that fluid containing the lymphocytes goes through our skin, when the skin is pierced or there is some sort of bacterial infection, fungal, parasitic, even metastatic, the first thing that will deal with this infection is the lymph system that is in the interstitial space and in the lymphatic fluid, in the lymphatic vessels. So its main purpose is the immunity. The main purpose of the lymph system is the immunity, and it's a very slow circulatory system. Let's go back to our second picture in the middle here. So we can see the blood went through the artery, through the capillary, and back to the vein. And between the artery and the vein, it started an ultrafiltration rate from the capillary ending, where we had here the interstitial fluid. The interstitial fluid was loaded on the protein that we called the albumin. The albumin was metabolized in the liver, and then it started going through the primary lymph capillary, which is valveless and the passive component of the lymph system. And from a primary lymph capillary, it passed to a precollector. And now it passes again from precollector to what we call a collector, of course. Still, we have the same active component, the bicuspid valves, the lymphangions that pushes the fluid upwards against gravity. And from primary lymph capillary to precollector to collector, and then we start going through lymphatic trunks. It's a big trunks, and from the big trunks, the fluid starts propagating to what you know all, what we call the lymph nodes. It reaches the lymph nodes. Our body have got a lot of lymph nodes, about 600 lymph nodes or something, and the lymph nodes are distributed all around our bodies because every lymphatic fluid have got to go through this lymph node. For instance, we can see the lymph nodes under our axilla, and we call it the axillary lymph nodes. Axillary lymph nodes. We can see it in the groin area. We call it the inguinal lymph nodes. And at the face, we can see the cervical, the submandibular, the submental lymph nodes, the supraclavicular lymph nodes. And if you can see me, I will show you. Now we can see the cervical lymph nodes. It's here. Can you see me now? Can anybody say yes? You're seeing me? We're talking about the lymph nodes in the cervical region. Yes, you're here. Tasneem, thank you. Okay, I'm still alive. Now I'm still alive, as I can see you. So, thanks. We've got the cervical lymph nodes, the supraclavicular lymph nodes just above the clavicle, and the pre and the post-auricular lymph nodes. And we can see here the occipital lymph nodes, the submandibular and the submental lymph nodes under our jaws. We talked about the axillary lymph nodes and the inguinal lymph nodes, of course. And of course, we have got lymph nodes everywhere in our body, even beneath the liver, the kidneys, around our intestine, what we call the cisterna chyli, because it have the lymph fluid is very cloudy at the cisterna chyli. It holds a lot of fatty acids and waste products. It's very cloudy. In normal, the lymph fluid is a colorless fluid, and it has, you know, a very distinctive smell. You can smell the lymph fluid from far away. It's very distinctive, and for the first time you will think it's a pus. You are smelling a pus or something. It's not a pus. It's the smell of the fatty acids in the fluid itself, and you will see it when you see someone with a lymphatic edema oozing lymphatic fluids. You will always smell the same smell at every patient without any infection. Again, we were talking about the lymphatic fluid when it reaches the lymph nodes, those 600 lymph nodes. They will start accepting the fluid from their afferent, and then it comes out from an efferent loaded with the lymphatic loads. And the lymph node will add to this fluid what we call the lymphatic loads, which is the fatty acids and the lymphocytes. The lymphocytes is the first skin defense mechanism. So we have got the T lymphocytes and the B lymphocytes. Those lymphocytes will be responsible for killing the bacteria and the fungus and the parasites in the blood circulation or in the interstitial space, if I may say. Now, continuing our circulation, we started from the artery back to the vein, and between the artery and the vein, we have seen the fluid in the interstitial space. It was loaded on the albumin, manufactured in the liver, and then it started walking from the precollector to collector to lymphatic trunk to lymphatic duct, and then to the lymph nodes. And from the lymph nodes, all the fluids in our body will start accumulating in one big duct. It's located in our abdomen and next to the spinal cord, next to the spine, deep in the abdomen, and we shall call it the left thoracic duct. It resembles, you know, it resembles the zipper in our jackets. It's the same, but just beneath the spine. The diameter of this left thoracic duct is about 1.5 centimeters. It's the biggest duct in our body. And it drains the fluid from all over our bodies, all over our skin, except for our right hand and our right side of our face. It drains the fluid from all over our bodies, except for the right side of our face and the right hand. This is anatomical structure, that's all. The next question, what happens to the lymphatic fluid in our right hand and our right side of our face? It starts to go through another small duct. It's called the right lymphatic duct. So we have the left thoracic duct and the right lymphatic duct. Those are the two main ducts that drains the lymphatic fluid from all over our bodies. Now the lymphatic fluid from the left thoracic ducts starts propagating upwards till it reaches the venous end again through a vein, what we call the subclavian vein. Subclavian vein. It reaches the subclavian vein from what we call the lymphovenous angle. It's coming from the lymph and going to the vein, so we call it the lymphovenous angle, the angle that connects the lymph system to the venous system. Now the lymphatic fluid is in the venous circulation again. It returned back to the vein, and from the vein it starts to propagate, going back to the heart through the posterior inferior vena cava, and the heart will start pumping that fluid to the kidneys, and from the kidneys it will be filtered and go back to urine. So this is a small introduction to how the lymph fluid is manufactured or ultrafiltrated in our interstitial space. And what is the function of the lymph fluid? It's loaded with the lymphocytes. It's all the time dealing with bacteria and pathogens in our system. And how is it filtered and how is it resorbed back to our system? Now, if we want to ask ourselves a question, if there is fluid, I'll try to change that color. If this fluid that comes out in this area, if it stays in this area without going back to the lymph system, what could make this edema happen? Because at the very beginning, when you see a patient with a fluid in this area, you will not call it a lymphatic edema. When someone comes to your clinic and says, my legs are edematous or swollen, this is not a lymphatic edema unless you ensure that it is a mechanical failure in the lymph system, because there is many types of edema. Today we will try to show you what's the difference between the lymphatic edema and the other types of edema or the dynamic insufficiencies. So when you see your patient for the first time, you will have to write on your paper at the very up right side of your paper, I have seen edema, not lymphatic edema, and you put 2 question marks till you assure that this is lymphatic origin. Okay? Type. Let's go through this. What can cause an ultrafiltration rate from the capillaries here? The first thing we will be talking about the normal circulation that we have just discussed, and go through this circulation step by step and see if something happened in this circulation. How would the fluid accumulate in our bodies? First, we said that the fluid goes in through the artery and then back through the vein. What if the blood pressure in the arterial end was not 100 millimeter mercuries and it was like 150 or something? If someone have got a peripheral arterial disease or atherosclerosis, the blood pressure would be very elevated at that point or at that site. It will allow an ultrafiltration rate from the capillary ending because the pressure is very high at the arterial end. If this happens, we will not call the edema accumulated here a lymphatic edema. It will be called arterial edema. So the first type of edema we are talking about today is the arterial edema. Again, if we go to the circulation, we go again to our circulation. It started with the arterial end and it ended with the venous end. You know, the veins have got bicuspid valves. Bicuspid valves prevents the fluid from returning back again. So when it's sucked by the heart upwards, the bicuspid valves here prevents the fluid from coming back. If someone have got a chronic venous insufficiency, that he have got an incompetent valves. Incompetent valves means that the fluid will go through the vein and it cannot propagate upwards. So it goes through the vein, and the bicuspid valves, as you can see here, it's not working. So the fluid will not go up because those valves are not functioning anymore. That causes the blood pressure at the venous end to elevate. If the blood pressure starts to elevate at the venous end, it will cause an ultrafiltration rate from the small capillaries at the skin. And at that point, we will have another type of edema that we will not be calling it arterial edema. We will not be calling it lymphatic edema. We will be calling it a venous edema. So the first type of edemas we have seen is the arterial edema. The second type we saw was the venous edema. And now we go through the fluid in the interstitial space. If the fluid starts accumulating in the interstitial space naturally, and there is no problem with the artery, no problem with the vein, and the fluid did not find the small protein that we were talking about that we called the albumin that will suck the fluid with the osmotic oncotic pressure and starts going through the primary lymph capillary. In this case, we will call this edema. In this case, if we don't find this albumin, we will call it hypoalbuminemia. And the hypoalbuminemia is it's a form of a dynamic insufficiency. There is no mechanical failure in the lymph system. This is not lymphatic edema. Again, if you look at the liver, there may be something like liver cirrhosis or virus C, whatever causing the liver not producing the albumin. In this case, the hypoalbuminemia or the decreased amount of albumin in serum lower than maybe 3.5 will cause an edema that is not a lymphatic edema. And by the way, it's not treated by the complete decongestive therapy. And the best thing we can do to help a patient with hypoalbuminemia edema is just to leave him for his professor, his internal medicine or the liver professional to start treating him. He may be treated by injecting albumin, human albumin every 12 hours maybe or something, not by manual lymph draining and compression massage. It's very risky to do this because in this state, you will be transferring the fluids. There will be only a fluid shifting because there is no albumin all over his body. If I'm doing manual lymph drainage, I will be sending the fluid from one space, maybe in his legs, to his thighs. And if I'm doing a compression to the thigh, you will find that the genitalia is increasing itself again because all over his body the albumin is not adequate. And the solution for this is not the manual lymph drainage. The solution is starting to treat the liver and adjusting the albumin level in serum. Again, what can make the albumin levels decrease in serum? The first thing is the liver, of course. Maybe the liver is not manufacturing albumin as before. And the second thing, guess what? It's the can we start interacting with each other? Do the participants have the ability to write me something? So we were talking that the hypoalbuminemia is due to liver cirrhosis. What do you think again can make decreased albumin levels in serum? Can anyone write?
It's there already. One answer from Dr.
Yeah.
Maram. Malnutrition.
Malnutrition, right? Yes, thank you, Dr. Maram. Because the malnutrition will make the intestine not absorbing the protein from the intestine, and it may cause a hypoalbuminemia or hypoproteinemia in the interstitial space, causing an edema. That's right. But maybe a severe malnutrition, like a patient in the ICU unit and he's not eating and injecting fluids all the time, the hypoalbuminemia from malnutrition, you're right, may cause an edema. This is not a lymphatic edema. Again, let me continue. Some patients with elevated renal enzymes or decreased renal function with an AKI or an acute kidney failure may cause the albumin to be excreted in urine. And when there is a microalbumin or macroalbumin in urine, the concentration of albumin in the interstitial space starts to go down. When the concentration goes down, again, it's the same problem. The liver cirrhosis, no compression therapy, no manual lymph draining. The malnutrition, no compression, no manual lymph drainage. Again, with the kidney failure, there will be a hypoalbuminemia again, and we will not be able to do our complete decongestive therapy. And unless there is a combined form of edema, of course, when we have our intensive course along with our nice rehabilitation academy and Mr. Job and Joseph, we will have our hands on to see how the texture of edema, of every edema would be, because the arterial edema is completely different in assessment from the venous edema, from the chronic venous insufficiency. And for instance, I can tell you that the edema coming from the hypoalbuminemia is not rich in protein. And when you put your hands in this edema, you will feel as if you're putting your hands in a gum. You know, if you're eating a gum and you're putting your fingers in a gum, it's very low in protein. Not like the lymphatic edema. The lymphatic edema is rich in protein, and those proteins in the interstitial space, in the presence of the sugar and starch, it starts converting to proteoglycans and fibrous tissue. And the formation of the fibroblasts cause it to be very stiff and hard. But in this situation, in the hypoalbuminemia situation, the protein's concentration in the interstitial space is very low. And by assessment of this patient, without seeing any investigations, just by putting your hands in the edema, you will say, okay, this is a hypoalbuminemia. It's not a lymphatic edema because it looks like a gum and you can move the fluids. There is no protein accumulated. And of course, the hypoalbuminemia would be seen all over the body of the patient, not in a quadrant or one leg or one hand. You'll see it all over his body, symmetrical, bilateral, both hands, both feet, if there is a severe hypoalbuminemia. So as we go through our causes of edema, not lymphatic edema, the causes of edema may be arterially, may be venous. Again, it may be a hypoalbuminemia due to liver cirrhosis or liver failure. It may be due to malabsorption, just like our nice doctor said. It may be due to kidney failure. And these three types, we call it hypoalbuminemia. So now we start going through the lymph system itself. When the fluid starts going through the lymph system, if there is a mechanical failure in the lymph system, this is what we call the lymphatic edema. If the fluid enters the lymph system, and after entering the lymph system, it fails to propagate against gravity in the lymph system, then this is a mechanical failure in the lymph system and it couldn't go anymore. That's what we call the lymphedema. The lymphedema is the main topic that we have got to take it in consideration and do the complete decongestive therapy for its treatment. And of course, not every type of edema could be treated with the complete decongestive therapy, but mainly the lymphatic edema is treated with the complete decongestive therapy. The venous edema, some sorts of venous edema could be treated with the compression therapy and the complete decongestive therapy. And of course, we have got protocols in planning for treatment, because for instance, if you are treating a venous edema, in this state, the lymph system is very free. There is no mechanical failure in the lymph system. So you don't have to go to activate other lymph nodes away from the affected limb. You don't have to go to the axilla and the abdominal stimulation, because the lymph nodes in the groin area, for instance, would be sufficient and working nice and slow. So you can go directly to activate the inguinal lymph nodes, because the failure here is at the venous end, not in the lymph system. This is only an example. I'm not going to lecture it now, because the chronic venous insufficiency of the venous system is a big issue to discuss. It may take like 1 hour or more to talk about the chronic venous insufficiencies and the stages of the chronic venous insufficiency and when the edema appears and what are the clinical pictures and the symptoms of chronic venous insufficiency and how could it be treated. This is more than 1 hour of practical lecture. Let's get back again to our picture. We started with the arterial edema. We have gone through the venous edema, and now when we saw the fluids accumulating in the interstitial space, we called it a hypoalbuminemia, and we said it may be hypoalbuminemia from the liver, from the kidney, from the malnutrition, and when there was a mechanical failure in the lymph system, we called it a lymphatic edema. What causes a mechanical failure in the lymph system? This is a very nice question. What causes a mechanical failure in the lymph system? We have got two main causes for the mechanical failure in the lymph system. The first cause is the primary lymphatic edema. Primary means the patient maybe he was born with hypoalbuminemia. Sorry, I meant that you have got less lymph capillaries or less lymph nodes. We call it hypoplasia. Okay. In hypoplasia, the patient is born with less amounts of lymph nodes or maybe less amounts of lymphatic trunks, and this is the most common cause of primary lymphatic edemas, hypoplasia. The second type is the hyperplasia. The hyperplasia, the patient is born with malformations in the lymph system. It's like an overproduction of the lymph trunks. It's accumulated, aggregated, and a lot of lymph nodes, but they're not functioning. And in some patients, they have an aplasia. It's the third type of primary lymphatic edema. Aplasia, the patient or the kid is born without a lymph system. Imagine he would be born with edema all over his body. It's very devastating to see a small kid without a lymph system. Maybe we will see a picture today. I'm not sure if it's in the lecture, but going through the lecture, maybe I can show you some pictures out of my lecture. So we were talking about the causes of the lymphatic edema, and we started with the primary lymphedema. It's primary. And the secondary lymphatic edemas. Secondary lymphatic edemas is due to an external factor that caused the mechanical failure in the lymph system. And today in our lecture, we will be giving some examples of the secondary lymphatic edemas that causes a secondary cause for the mechanical failure of the lymph system. And of course, there is the third type, and it is a combined form of primary and secondary lymphatic edema. Just like a patient with a primary lymphatic edema hypoplasia, and when he is born, no edema appears on that patient because his body is struggling to get rid of the fluid, and it's somehow holding itself, and the fluid is not accumulating in the lymph system because other lymph nodes are working more and more. As you know, the lymph system can work maybe 50 times more than its original work. So the lymph system would be working by all its effort, and at some point that small kid have a contusion or ankle sprain or something, just like all the kids. But in particular, this kid will develop a lymphatic edema. This is a primary lymphatic edema that appeared because of a secondary cause. It was the contusion. Not everybody have got a lymphatic edema due to contusion, but because he had the predisposing factor that caused him to enter that lymphatic edema, he is now a secondary lymphatic edema or a combined form of primary and secondary lymphatic edemas. Again, we go through the causes of the lymphatic edema. We started with the arterial edema, through the venous edema. We have gone to the hypoalbuminemia and its causes. We had the mechanical failure in the lymph system because of the primary and the secondary lymphatic edemas, and we said that the primary is the hypoplasia and the aplasia and the hyperplasia, and the secondary causes may be an external cause, maybe a lymphadenectomy, maybe cancer, maybe radiation, maybe filariasis. We will be talking in the next slides about this. The next slides will be more interesting. I know we have been all the time talking about the main circulation, and it's not that interesting to see this picture, but as we go through our lecture, I think you will be interested. But you must have those basic information before going through the treatment procedure and what we can do for the treatment. So next, as we said, after going through the lymph system, it starts going back to the subclavian vein and back to the heart. Imagine if someone have got a left ventricular diastolic dysfunction or a right side heart failure where the blood, the heart can pump the blood, but there is no filling back. The diastolic function of the heart is not working as much. The blood pressure would be very high at the venous end all over the body. And by the effect of gravity, you will see the two legs of this patient swollen, just like this. In this form, this is not a lymphatic edema. It's not arterial, it's not venous, it's not lymphatic origin. This edema, what we call a cardiac edema. And of course, a cardiac edema is not treated by the complete decongestive therapy because only the compression would cause the precardiac load to increase and the blood pressure at the pulmonary artery increasing. This may cause death or something. And I used to say always in my lectures that as physiotherapists, and I'm a consultant physiotherapy, we are used and that if something went wrong during the session, the patient may tell me that my pain level was 3 and you made me feel 5 pain, you are a bad doctor. But in lymphedema, you will not hear a complaint. The patient will die. You will have to be very accurate in diagnosing the patient. If you do compression for a heart failure, most probably the patient would not be able to take his breath during sleep. If you do a compression therapy for an arterial insufficiency, the patient may go through the gangrene and then he chop his leg off and then he go to the intensive care unit and then he dies. That's why you must know all the concepts and all the circumstances before applying your complete decongestive therapy, and you become a very talented doctor in diagnosing the patient and making sure that he is indicated for this type of treatment. And if he is not indicated, somebody else will help him, not you. Okay? We do know our limits. We know when to start and when to stop. Okay? So again, before I leave this page, the edema may be primary or secondary. The causes may be arterial, venous, hypoalbuminemia, liver cirrhosis, kidney failure, mechanical failure in the lymph system, primary or secondary lymphatic edema, heart failure, kidney failure. There is many causes of, as we wrote on the upper right side of our screen, edema. It's not lymphatic, it's called edema. Okay? And we can then distinguish between the dynamic and the mechanical insufficiency of the lymph system or of our body. Okay, it was a very long story in this picture. Let's go through the other pictures and start propagating our lectures today. Oh yeah. Our markings have gone all over the slides. I have to take it off. As I told you before, my friends, fellows, that I will show you the lymphangions or the precollectors and the collectors, as you can see in this picture. I've been writing for about 1 hour. What's all this? Okay. Okay. So as you can see here, can you see my marking? Yeah. As you can see here, here is what we call the bicuspid valve inside the lymph collector. That bicuspid valve starts to open, and when those bicuspid valves open, the lymph fluid starts to propagate through that tiny hole to go through another chamber. That other chamber have got what we said, the lymphangions, the micro muscles, the micro smooth muscles that are inside the lymph vessel. Those lymphangions starts to contract, and by its contraction, it pushes the lymphatic fluid from that state to the other bicuspid valve where it opens again. When the bicuspid valve opens, the lymphatic fluid starts to propagate. But if the patient have got a lymphatic edema, most probably that bicuspid valve would not be functioning. And as you always hear that the lymph system is blocked, it's not that blocked, but it's just like the chronic venous insufficiency. The fluid cannot propagate through the lymph itself, through the lymph collector itself. So the bicuspid valve is doing like this, okay? It's not working, it's not functioning. So the fluid can go and return back, can go through against gravity, and it can come back again and accumulate at the first chamber. The bicuspid valve is not functioning anymore. What causes the lymph fluid to regurge in the lymph system? Maybe a chronic inflammation or a low-grade inflammation. You know, you have all heard about lymphedema. It's trending nowadays, the lymphedema, and of course, when we meet, inshallah, very soon, maybe next August in Kuwait, I think. Mr. Robin Joseph, are you with us?
Yeah, sure.
Yes,
So we'll.
I think you will welcome me in Kuwait in next August. Am I right?
Yeah, sure. Or before, once we open, the government open the visa and the
Yeah.
airport, we are ready. We are ready for you to see here. We have a
Okay.
couple of participants already registered.
Many participants.
Yeah, we have a couple of them.
Okay. I'm
And
very interested and encouraged to go to Kuwait. It's a very nice country, and I like the people there. I've visited it once before in Salmiya. Am I right?
yeah. This time also
Yeah.
it will be held in Salmiya.
Okay. Perfect.
Okay.
I think, inshallah, it would be next August.
August, inshallah. Sure.
Okay, inshallah. So we go back to our slides. We were talking about the mechanical failure in the lymph system due to a low-grade inflammation, just like what happens in lymphedema, the accumulation of fat cells in the interstitial space, causing the interleukins and the inflammatory mediators to stagnate in the lymph system, causing pain and low-grade inflammation. At a late stage, it may cause a lymphatic edema, and that's what we call a lymphedema. Okay, it's a secondary form of lymphatic edema. So we leave that slide and we go through another slide. It's a cross section of a lymphatic vessel, and I leave it. Mr. Robin, can we take some questions before we go through the secondary lymphatic edema's causes, or you think I should be continuing lecturing?
No,
Continue
sure. We
lecturing.
can. No, we can have a Q&A session. Those who are interested or those who have any queries, let them ask.
Okay, but I cannot see their questions now as I'm sharing my screen. So if there is a question, maybe you or Dr. Menna can tell me the questions, a little question maybe, or a couple of questions.
Sure. If anybody wants to ask any questions right now, you can either chat in the chat box or unmute yourself and ask the question.
Okay.
Hey, thank you so far. Very, very informative, Dr. Michael.
Thank you. Thank you.
I have
I'm
a
Michelle,
question.
by the way.
Michelle. Okay, sorry, Michelle. Can you go over the lymphedema, the mechanism of it again?
Okay, no problem. It was not planned to discuss it, but as you asked, I will say it. Look, first, the lipodema, it happens because of one of two. Maybe it's hormonal imbalance or hereditary. It comes from the parents, from the mother, of course. And it appears during puberty. So when a little girl is going through her puberty, it starts feeling that there is accumulation of fat cells in her adipose tissue. That fat cells is made to keep the energy for a long time. It's not that brown fat cells that we all, when we do a diet or something, we lose those fats. It starts accumulating in the adipose tissue. And the accumulation of the fat cells in the adipose tissue, it causes a low-grade sort of inflammation, because the fat cells will prevent the lactic acid and the interleukins from moving in the interstitial space through the lymph system and back to the veins. So they will be accumulating all the time in the skin. So that's why the lymphedema patient always suffers from a low-grade pain. No one can bear, if you touch a lymphedema patient, he will tell you it's very painful. Please don't touch me. Don't put your hands on me. Don't put anything on me. I don't like putting heavy clothes on me, because his interstitial space, including his skin, is always inflamed with a low-grade inflammation. Here, the low-grade inflammation compromising the lymph system and the peripheral venous system, especially the small venules, because you will see it always in the lymphedema patient having spider veins, or what we call a small telangiectasia. That fat cells compromising the lymph system, the small, of course, the superficial or the primary lymph capillaries, the venules, and the arterial system, will at the end cause a lymphatic edema. And in this state, the patient will have two forms of edema, a lip edema and a lymph edema. And in this form, we call it a lymphedema. As you know, the lymphedema is stages, and also the lymphedema is stages. We will go through our lecture, and I'll show you the stages, of course, of lymphedema. And when lymphedema appears with a lipedema patient, it goes through the same staging again. He may have a cellulitis or a chronic infection of his skin, and he starts having chronic lymphatic edema post-lipedema. Okay, and he's treated, of course, with the same procedure, the complete decongestive therapy from manual lymph drainage, compression therapy, compression garments, exercising, skincare. That's the international protocol. My nice doctor, did you have your answer? Yes or no?
Yes, thank you so much, Dr. Micheal.
Okay, thank you. Is there another question, or we go through our slides?
No, I hope we can go to the next slide.
Okay, so we were talking about the primary and the secondary lymphatic edemas, and I started putting here the causes of the secondary lymphatic edema, so we have a picture of what causes the accumulation of fluid. I'll choose one of them. Okay, here I will choose the advanced stage of diabetes. You all know in diabetes there is a peripheral arterial disease, there is a peripheral arterial insufficiency, and there is an inflammation in the joints, because at advanced stages of diabetes we see the Charcot joint, if you know it. Charcot joint is due to peripheral neuropathy of the nerve cells. That neuropathy causes inflammation at the joint itself. And sometimes the cartilage in the joint starts the wear and tear, and the inflammatory process increases in the joint. And due to this inflammation, the accumulation of fluid starts at the Charcot joint. This is a very advanced case, because to get rid of this fluid, you will have to do compression. And this is a combined form of edema or lymphedema, if I may say, because there is an arterial insufficiency, sort of arterial insufficiency, because of the chronic peripheral arterial disease, and it's combined with inflammatory process from the Charcot joint causing edema or a mechanical failure in the lymph system. In this stage, you can do the compression therapy, but a very low compression. And what makes you sure that the compression therapy is adequate, you must do a test called an ankle brachial index. The ankle brachial index measures the systolic pressure from the posterior tibial artery and compares the pressure with the brachial artery, so you can get a number that allows you to do the compression. If the number is more than 1, it's safe to do the compression. If it's less than 0.8, you will be at risk of doing compression of the gangrenes. But it's very advanced case to deal with a diabetic foot with lymphedema, if I may say, because of the peripheral neuropathy. The patient wouldn't be feeling his leg. If you do a high compression, he may have a gangrene without feeling. You will find his leg in a bluish coloration. He wouldn't be able to move it, and he's not feeling anything. And at the same time, the peripheral arterial disease would be affecting the patient. It's a very complicated case. The second case here we have, for instance, is the filariasis. Filariasis is a parasitic infection. It was, we used to see it in the Middle East, but thanks to the World Health Organization for doing the a mass drug administration, they started putting the albendazole to the endemic parts where the filaria is all over the country. So we got rid of this parasite because it transfers through the mosquitoes. You know, the mosquito have got to bite someone infected with the microflaria. The microflaria goes through the suction process in the mosquito, and then to the flying muscles, and then to her stomach, and then when the mosquito starts to suck blood from a sound person, it transfers the microflaria again to the person, where it starts to multiply and block all the lymph system and make an inflammation to the lymph system, causing secondary lymphatic edema. The bad news here, if someone is diagnosed with filariasis, when the signs and symptoms appear, the lymph system would already be damaged. So if he takes the medication for killing the microflaria, the patient will stay with a secondary lymphatic edema. Maybe it will not advance to a higher level, but we don't expect him to totally subside the edema. One of the most affecting cases, and all over the world, is the cancer and the post-mastectomy. When someone, or when a girl have got, it's the same. It happens to male and female, but the incidence is higher at the females. Breast cancer, there is a lot of surgeries made, like mastectomy, lumpectomy, partial mastectomy. Now, I think radical mastectomy is not made anymore. Lumpectomy is the most common surgery done for dissecting the cancer. But after the dissecting of the lymph nodes or the lymph adenectomy, the patient starts having edema at the upper limb. And of course, it's a very big challenge, because some patients have regional pain syndrome, like neural inflammation in that quarter of the body, or neuropathy, or muscle weakness, or drug-induced edema. Sometimes they have hypoalbuminemia with the upper limb lymphatic edema. It's very complicated. And in these cases, sometimes you see an active metastasis with the lymphatic edema. And here what we have to go back to the textbook of lymphology to ask, is the active mets indicated for compression and manual lymph drainage or not? It's a relative contraindication. It's relative contraindication. It's not totally contraindicated. Okay, if you are giving a better quality of life for this patient and he's diagnosed with a terminal cancer, for instance, maybe you can do your manual lymph draining and compression therapy. It's a big issue to discuss, of course, because it's debatable all the time, but so far we can do to elevate the quality of life for a poor patient in a terminal cancer. The emerging lymphatic form of edema is the post-surgical edema, especially the post-liposuction. All over the world now, it's well known that post-liposuction, post-tummy tuck, post-facelift, you must do a manual lymph drainage. And only a skillful certified lymph therapist should do it in a professional way, and knowing the expected outcome and giving a better quality of care for his patients. So post-liposuction, of course, the the lymph vessels get some sort of contusion, and there is edema and fibrosis and fibrous tissue. So they go through a protocol of treatment that may continue for 2 months of manual lymph drainage, along with the compression garments that the surgical doctor or the bariatric surgeon recommended. So we have discussed some sorts of causes of secondary lymphatic edema. If you are interested, of course, the chronic venous insufficiency is a main cause, but we don't call it a lymphatic edema. It's called a phlebo edema or phlebedema. And in case of phlebedema, the ultrafiltration rate with the high protein content and inflammation causes a mechanical failure in the lymph system. And just exactly as we said before, if the lipedema caused lymphedema, we call it lipolymphedema. If the phlebedema or the chronic venous insufficiency caused edema along with lymphatic edema, we will call it phlebolymphedema. If someone have got a lipedema with chronic venous insufficiency and lymphatic edema, we will call it lipophlebolymphodema. Okay, so it's that easy. And of course, the most common cause is the post-cellulitis and skin infection, because the infections cause a systemic inflammation, maybe the whole quadrant of the skin. It looks like if it's burnt, you will see the patient suffering. It's red, hot, he's shivering, his body temperature is elevated. It's a life-threatening condition. Cellulitis is a big lecture also to talk about the antibiotics and for how long should it be taken. Should we be taking the penicillin long-acting for how long? What is the side effects of penicillin? Where should it be induced? A lot of things on every topic of those causes would be lectured, of course. I hope you're still alive. My colleagues, my lymph colleagues, everyone is alive. Am I monotonous and everyone has slept?
No, we are with you.
Maram is still alive, and Dina again. Maram, thank you, Maram. Can you wake the other friends, please? Good morning. We're back. Habiba, thank you. Okay.
Hello, Doc. Still alive.
Okay, someone is alive. You're Fadila? Yes, okay. You're alive. Ainur, alive too. Okay, so everyone is alive. Rajan, thank you, Asghar. So we go through our lecture again. Don't go anyway. I'm about to finish. I said I'll be talking for 1 hour. I never stop talking. Now it's 4:15. Okay. That how it looks when your patient have a cellulitis. Can you see here? Can you see this picture? It's red, it's hot, he's shivering, his body temperature is elevated. Okay, can you see? And it starts with this redness, and this redness is because of the accumulation of the red blood cells in the interstitial space. So it starts red this way, and then the red blood cells starts oxidizing after the cellulitis subsides, maybe from the antibiotics. It starts oxidizing and it turns to a brownish coloration. So it starts red and then goes to brown, and then a fibrous tissue starts accumulating in this area due to recurrent cellulitis. It's a life-threatening condition. It have got many causes, but most probably the patient would have a little amount of fluid in his leg, maybe at the forefoot, and the fluid is not loaded with lymphocytes because it did not go up for the lymph nodes to be loaded with the lymphocytes. So this fluid have got no immunity, and when the patient scratches his skin or something, he starts developing cellulitis, and the cellulitis causes secondary lymphatic edema that is irreversible edema. Sometimes you see the lymphatic edema with blisters, as you can see in the middle picture. It's very similar to burn, to skin burn. And we have got nothing to do with the cellulitis. If your patient during treatment even If during treatment your patient have got a cellulitis or an active cellulitis, you should stop treatment at once, and we will start empirical antibiotics till the cellulitis totally subside. There is two levels of cellulitis. You may see cellulitis or an erysipelas, a bacterial infection of the subcutaneous, of the epidermal layer only. It's a very light form of cellulitis. To prevent our lymphatic patients from having cellulitis every now and then, because their lymph system is all the time affected and there is no lymphocytes, some doctors recommend taking penicillin. They recommend taking penicillin, and they take that injection, penicillin, long-acting. It's 1,000,000 units. They take it maybe once per month to stay or to keep the antibiotic particles in their interstitial space. Even there is no lymphocytes, the antibiotic will counteract any pathogen that enters the skin. So they take a long-acting antibiotic once per month to prevent the cellulitis or the impact of that life-threatening condition on the patient. Again, we were talking about the parasitic filariasis. It's very distinctive. You can say when you see someone that he is infected by filariasis. And I think in our Middle East, another sort of parasite that is present is the leishmania. It causes leishmaniasis and the skin inflammation. Sometimes it turns to lymphatic edema, but it's not the main parasite that makes the edema, because in filariasis, the parasite itself lives in the deep lymph system. When the patient is infected, the microfilaria starts moving in the superficial lymph system, and then it starts to migrate to the deep lymph system, where it becomes an adult worm, and then starts providing its waste products and the inflammatory mediators, and then here comes the inflammation, and the filaria starts, or the elephantiasis starts to appear again. Again, I think in the Middle East now, the filariasis has most probably subsided because of the mass drug administration. This is a big lecture. It may be said in, I think, at least 1 hour, but I meant to show you here this patient with an inguinal lymphadenopathy. Lymphadenopathy is an inflammation of the lymph node. And the lymph node starts inflammation if there is a bacterial infection, maybe at the genitalia or maybe at the lower leg. Any sort of infection will cause the lymph node to start dealing with that bacterial infection, and the pus and the lymphocytes will start accumulating in the lymph nodes and causing that picture. In some advanced cases, the very high inflammation at the groin region, along with the mechanical failure of the lymph nodes to kill that pathogen, a lower limb lymphatic edema will appear. And the most common cause from the sex-transmitted diseases is what we call the chlamydia. Chlamydia is the most common cause of inguinal lymphadenopathy and late stages lymphatic edema. And especially what is subdivided from chlamydia is the LGV, or the lymphogranuloma venereum. It's very famous for its affection of the lymph nodes. But the STDs, if left untreated, most of them will cause lower limb lymphatic edema. The STDs is maybe from a bacterial origin, from fungal origin, from parasitic origin, from viral origin, just like the human papillomavirus, the Epstein-Barr virus, the cytomegalovirus, the human immunodeficiency virus. Parasitic infections may be Trichomonas vaginalis. We can see some bacterial infections like syphilis, like chlamydia, like gonorrhea, like mycoplasma genitalium, like ureaplasma genitalium, and every one of those have got its protocol of treatment. And only by the good assessment, you can assessment and taking a good history and talking to the patient, you will discover that the main cause of the lymphatic edema has to be treated, because the infection will continue eating the patient, even if you're treating the symptoms. the main cause is still there. So you have to make a good assessment. You have to put a diagnosis, and you are sure of it before you start treatment. So if you discover that the patient is suffering from, for instance, an LGV, you will send him for the venerologist or the sexologist to start his treatment along with his partner, because his wife also would be affected, and the infection will be reintroduced to the patient even after the treatment with the antibiotics. It's a big issue, and it needed to be discussed in maybe at least 1 hour. And at last, what can we do to help lymphedema patient? We have got the complete decongestive therapy. It's the golden rule of the international protocols of treatment of lymphedema, and it's based on main components, 4 main components. Manual lymph drainage, as you can see in the picture. Am I using my pen? Manual lymph drainage, as you can see in the picture, in the lower right side of the picture, and it have got a lot of protocols, and it depends on dividing the patient's body into watersheds, where we know where the water is going to be filtered. As you see in the picture in the middle here, the white one here, are you seeing my marker? I'm not sure. Yes, here. You'll see that the patient in this quadrant, the fluids will be going to be filtered from the axillary lymph nodes. And on the other side, it would be filtered from the other axillary lymph nodes. And for his lower limb, the fluids would be propagating upwards to go to the inguinal lymph nodes to be filtered. So if I have a mechanical failure in the lymph system in this quadrant, I will try to make the fluid go and be filtered from other quadrants. This is what we do in the manual lymph drainage. We start to plan for treatment. In what part we start to activate the lymph system, which is before which. This is a long story, but now we have to know that the complete decongestive therapy is the main treatment plan for a lymphedema patient, and it starts with manual lymph drainage, and then we do a good skincare to prevent any infection, and then we do the compression therapy, and then we do exercising with the compression therapy to improve the lymph and venous circulation, and of course the arterial circulation too. This is a picture of using the indocyanine green. It's a material that glows in the dark when you allow the infrared lamp to go through on the injection site. It will show you that the lymph fluid is moving through the lymph capillaries upwards, so you can do your scientific research. Stages of lymphedema. We have got 4 stages in lymphedema. The first 2 stages are, someone's writing with me? It's not me. Okay. The first two stages, this is stage, this is me, and this is stage 0. And this is stage 1, and this is stage 2, and this is stage 3. So now stage 0 and stage 1 are reversible stages where the patient can totally be free. And stage 2 and stage 3 are totally irreversible stages. The patient will have to go through the complete decongestive therapy and the compression garments for the rest of his life. So how do we distinguish between the reversible and the irreversible stages? In stage 0, there is no obvious edema. Even after the mastectomy, there is no obvious edema at all, but the patient may say that I have a heavy hands, maybe a little pain. In this stage, we do the complete decongestive therapy, but without compression therapy, because the side effect of compression may cause an edema, if it's not that adequate, I mean. In the first stage, we will see the patient with a minimal edema, but this edema, when the patient starts lying down and his hands is at the same level with his heart, it totally subsides, taking all the fluids and the proteins from his hands back to the lymph system and back to the heart. This stage is still a reversible stage. We can treat treat it in a whole way, because every day the patient gets rid of the proteins in his interstitial space. That's why it will not go to a form of fibrosis. So you can still serve or still save that patient. But here, starting from stage 2, he will when the patient goes to sleep and the hands is at the same level of the heart, the edema will start to subside, but not as at the very beginning. In this stage, it's an irreversible stage, because every day the patient will leave some sort of protein in his hands, and at the end he will have to do the manual lymph drainage, the compression therapy, and at the very end, after the decongestive phase, he will have to wear his compression garment long life again. Stage 3, of course, it's a form of stage 2, but with elephantiasis and recurrent cellulitis. I don't like the elephantiasis word. It's very cruel for the patient to say you have elephantiasis, you look like an elephant. Okay, we say it's stage 3 when you have recurrent cellulitis along with permanent lymphatic edema. And of course, all stages have to be treated, but we have to be true with the patient. We have to tell him his case and what is the expected outcome of our treatment. So we tell him that our treatment in those 2 stages is a preservative treatment. We will prevent any further side effects. You will not have more cellulitis. Your hand will not go further than this. It will be decongested, but take care. If you leave the compression garment, it will return again to be edematous. This is a successful story where we had a patient with inguinal lymphadenectomy in the German Lympho Center here in Egypt. As you can see, that nice woman, she had an inguinal lymphadenectomy from the inguinal lymph nodes here. And what you can conclude that the edema was here proximal more than distal, because the lymphangiomotoricity is working and the transport capacity is working. But when the lymphatic fluid reaches this area, it didn't find the inguinal lymph nodes, and that is where it started accumulating. That's why when you are diagnosing a patient with an edema, if you see the edema proximal more than distal, the first thing you should be thinking about is the metastasis and the cancer. Because if the lymph nodes are blocked with fibrous tissues and it has lost its helium and nucleus, it wouldn't be able to filtrate the fluids from the thigh. You will find the edema first at the proximal region before you see it at the distal. But if someone with lymphatic edema, with a classic lymphatic edema, always by the effect of gravity, you will see the fluid accumulating on his forefoot, not in his upper thigh. And of course, after treatment of this nice woman, she could wear a nice garment. As you can see on the right side of the picture, she was wearing a flat knitted made to measure garment and a compression toe cap for her fingers to prevent the edema going down to her fingers. This is a success story from Sudan. That nice woman, she was affected by filariasis, and we were successful doing the compression therapy and the manual lymph drainage, and at the very end she reached that result. And by the way, that happened I think 2009 or something, and that girl started contacting us again. She sent new pictures for her leg. She was very nice, and she was sound and safe, and she was just asking to do her compression garment again. So she's nice for more than what can I say, 16 years now. I've left her maybe from 16 years. She contacted us again and she sent pictures of her leg. She's sound and safe after 16 years of this picture. I'm so proud. So at the end, I welcome you all, and I'm very happy to see you all again. And with the interaction with the lymph fellows and lovers, Sir Oliver Gültig told me to send his congratulations till he see you again, maybe in the next. I'm not sure if he would be able to come in next August, but it gives me a great honor to be with you and the nice academy of the Rehabilitation Academy. And I would like to thank Mr. Joban Joseph for this invitation. And I'm very happy to be with you and motivated to see you again in Kuwait, inshallah, in Salmiya very soon.
Thank you, Dr. Micheal, for your
Thank you.
wonderful session. And
Thank you.
Gültig Lymphology for delivering this webinar for our participants in Kuwait and India and UAE. I think all have had a good time, and we hope to see you in Kuwait very soon, inshallah.
Thank
Thank
you,
you.
and thanks
Once
for
again.
everyone. Thanks for interacting, and thanks for everything. Till we meet again. See you.
See you.
See you. Bye bye.
Any
Bye.
questions? Doctor, give me a
Yeah.
moment.
Why not? If anyone wants to ask something, no problem.
Yeah.
And they can write it on the chat.
Yes, thank you for an informative lecture. It would be